Hello everyone, this is Dr. Neelesh Singh, Senior Lecturer in the Department of Periodontology, Babu Banarsidass College of Dental Sciences. Today I am going to discuss a topic, aging and periodontium. Now by the title aging and periodontium, what we can understand is that we are going to study the effects of aging on the periodontium. In today's world, there is an increased health awareness and improvements in medical and dental fields. There are a lot of improvements in mental health, living, life, fitness, sport, etc. etc. Hence, we can make out that because of all these things, there is an increase in life expectancy and demand for periodontal treatment is increasing. Particularly the maintenance therapy, especially the scaling and root planing part. Therefore, an understanding of the impact of aging on the periodontium is extremely critical. Now, the effects of aging on the periodontium we can divide in various parts. Firstly, we can study the effects of aging on the gingival epithelium. This is the diagram of gingival epithelium. In the aging, there is a decreased thickness of the total epithelium. Because of this, there is an altered cell density and there is a decreased keratinization on the top. There is also a flattening of ratapex seen. In this picture, the flattening of ratapex is not seen because this is not the picture of aged individual. I have just placed it because to understand what is ratapex. Now, ratapex are the finger-like projections of epithelium into the connective tissue. They mainly act as an anchorage and helps in the protection from functional trauma and other types of traumas. So from here we can see that our epithelium has become weak to the bacterial attack and decreased resistance to the functional trauma. Now, in older individuals, gingival recession has been seen very often. Now, what is gingival recession? Gingival recession is basically the exposure of the root surface by the apical migration of the gingiva. Here is some surface anatomy of the gingiva. Please follow my pointer. In between the teeth, this triangular extension of the gingiva, we call it as interdental papilla. The collar which is surrounding the tooth is known as pregingival margin. It is not attached to the underlying tooth or the bone, hence it is free and known as pregingival margin. Beneath this pregingival margin, the part of gingiva is attached to the tooth surface or the underlying bone, hence the name attached gingiva. Beneath the attached gingiva, there is movable portion that is known as alveolar mucosa. In between these two, first attached gingiva and the second alveolar mucosa, there is a junction which is shown here by this black solid corrugated line. This is known as mucogingival junction. As the name suggests, it is a junction between mucosa, gingival means attached gingiva. So it's a junction between alveolar mucosa and the attached gingiva. So we have seen that recession will be there in the older individual. So if by this diagram, we can understand that if the recession is there, the marginal gingiva goes apically towards the attached gingiva. Hence, the width of attached gingiva will be reduced in the presence of any kind of recession. But in the aging, it doesn't happen. Why it is? This can be explained by this diagram, which is taken from Carranza book. In this diagram, the A portion explains the normal relationship between the tooth and the gingiva. This solid red line explains the position of the gingiva in the normal situation. Now, what happens in the aging? First of all, we have to understand a very basic concept that our teeth are not in the static position. In the complete lifespan, they continue to erupt. Now, why they continue to erupt? Because during the function, they contact with the opposing tooth. The lower one in contact to the opposing tooth, and hence they lead to atresion. Now, this atresion results in loss of contact between these two. Now, what happens is the body produces more and more eruption of the tooth to meet the opposing or antagonistic tooth so that the contact is re-maintained. In this B portion, it has been shown by this black arrow that it is a continued eruption resulting from atresion and the tooth surface loss. So the tooth is continually erupting. So what happens is the gingiva is remaining at its original position, but the tooth is continually erupting and it comes out of the gingiva. So what happens in the result? There is an exposure of the root surface from the gingiva, and this leads to a recession. So the key fact is that gingival recession is not an inevitable consequence of aging, but is the cumulative effect of trauma or the periodontitis. Now, periodontitis, we all know, is a disease of the periodontium. It is inflammatory disease and which can also result in the gingival recession. Now, coming on to the effects of aging on the gingival connective tissue. Gingival connective tissue is present beneath the epithelium, and with the aging, it becomes more dense and more coarser. Now, what happens is there are quantitative and qualitative changes in the collagen. The soluble collagen becomes insoluble. There is an increase in mechanical strength of the collagen, and also the temperature of denaturation of collagen increases. A very important point to be noted is that in the aged individual or the older individual, there is no new production or very minimal production of new collagen. All the changes which are taking place are in the old collagen which is previously present. Now, the effects of aging on the periodontal ligament. Periodontal ligament, as we all know, is a tissue which is present between the root surface and the bone surface, and it holds the tooth in its socket. Now, there is a decrease in the number of fibroblasts in the aged individual. There is more irregular structure and all those things. Main thing is that the PDL cells, periodontal ligament cells, they show less proliferation, and hence the healing is also slow, but it is not so pronounced that clinical effects can be seen. Then the periodontal ligament space, that is known as PDL space. The PDL space is not age dependent. Now, on what thing it is dependent? It is dependent on the functioning of the tooth. Now, if the tooth is in function, that is, if it is in contact with the opposing tooth, then the PDL space will be wider because the contact between the teeth activates the PDL. And if it is in no function, or if it is there is no contact between the tooth to the opposing tooth, then the PDL space reduce in the thickness. Now, the effects of aging on the cementum. Cementum is the outer covering of the root. We all know it. There is an increased thickness of the cementum with the age. It is a very simple concept which has been found that the cementum continues to be deposited on the root surface till the whole life of an individual. In the older individual, as we can see the data, it is 5 to 10 times more than the younger adults. Now, maximum deposition of the cementum takes place in the apical region and the lingual region. Now, you can see this tooth, which is from the older individual. If you can see the radiograph and appreciate, we can find out the lining, actual surface of the tooth. And after that, what we can see is the excess cementum deposition with the age. So, this is the main change of the aging on the cementum. Effects of aging on the alveolar bone. Not much changes has been found in the alveolar bone with the aging. Main thing is that fibers are more irregular, and some reduction in the fibers are also seen. An important point is that there is no change in the bone healing, or very minimal changes between young and the older individuals. A very simple example is that if we extract the tooth of a young individual and an older individual, the amount of healing rates will be almost the same. Another example is that the osseointegration of the implants. The implants also heal almost equally in young and the old individuals, provided none of the person, young or the individual, have any systemic illness which affects the healing. Contrary to all this, if we take the bone graft from a aged or the older person, it has a very low bone generating potential, osteogenic potential. So the bone generic potential of the bone graft taken from a older individual is less. It is a very important point to note that the effect of age-related systemic conditions like osteoporosis on the alveolar bone should not be considered as the effect of age on the alveolar bone. The condition is osteoporosis. The osteoporosis is basically the condition in which the bone mineral density of the whole skeleton is reduced. So it also affects the alveolar bone, but the effect of osteoporosis on the alveolar bone should not be considered as the effect of age on the alveolar bone. Then coming on the effects of aging on the plaque. With the aging, it has been found that there is an increased accumulation. Now, age-related recession exposes the root surface, I have told it earlier. So more hard surface is exposed and the texture of the root surface favors more plaque accumulation. The root surface texture is more rough as compared to the enamel. Another important point to consider is that in the older individuals, the dexterity of the brushing is reduced. The brushing is less efficient. Hence, more and more plaque accumulation will be found. The another important thing is qualitative change in the supra and subgingival plaque. Supragingival plaque has been reported with no change, and subgingival plaque has been reported with a lot of changes in the number and type of bacterial species which is found. For example, in the older individuals, the role of this Agrigentibacter actinomycetum comitans bacteria is decreased. This bacteria has been found to be playing a very important role in the periodontal disease pathogenesis in the young individuals, especially below 30 years of age. So this is the effects of aging on the plaque. Mombelli et al. Found that these changes are because of ecologic changes in the oral flora with the age. As with the age, the ecology of the oral cavity also changes. Now, the coming on the effects of aging on host response. Now, what is host response? Host response is basically the immune response of an individual. First of all, to study this, we have to exclude the diseases and the conditions which affects the body's immune response, and mostly they occur in the older individuals, especially the diabetes. Diabetes changes the immune responses. Now, because of aging, what kind of changes have been found are there's an increased gene expression of interleukins, increased gene expression of macrophages, and increased C-reactive protein. C-reactive protein is basically a marker of systemic inflammation. Systemic inflammation is how much is determined by the C-reactive protein. But all these changes are very less pronounced, and hence they are clinically insignificant. Now, the effects of aging on periodontal disease progression. Now, what is periodontal disease progression? Progression means how the disease is progressing from the normal state to the most severe state of the disease. In a classical experimental gingivitis study, the subjects were rendered free of plaque and accumulation through frequent professional cleanings. And after that, both the type of individuals, the young individuals and the older individuals, were abstained from all type of oral hygiene measures for 3 weeks. And after 3 weeks, when they were examined, it was found that there was a greater inflammatory response in older individuals. So, if a disease is allowed to progress, it will be more in the older age group. Now, if we consider the risk factor, all those slides we have read is showing us that age should be considered as a background or an associated risk factor rather than a true risk factor, because the age has a very less or minimal effects or no effects on the periodontium. Then coming on to the effects of aging on the treatment of periodontal diseases. A lot of studies have been found that despite some histological changes in periodontium due to age, there are no differences in response to non-surgical and surgical therapy. Now, what important thing lies is plaque control. Now, see, if a young individual is getting periodontal treatment, and after periodontal treatment, he is not maintaining good plaque control. then in young individual also there will be a bad treatment response. And if in an older individual he is maintaining plaque control after treatment, then the response of periodontal treatment will be very good. So the key fact is the biologic effects of aging have either no impact or minimal impact on an individual's response to periodontal treatment. However, other factors may have a profound impact like cognitive factors, motor skills, and any type of systemic illnesses, especially the diabetes, which mainly alters the host response and the periodontal disease pathogenesis. So this was all the effects of aging on the periodontium and periodontal disease prognosis. So the conclusion lies is that aging is an associated factor or it is a background risk factor for periodontal disease pathogenesis, and it is not a true risk factor like smoking and other things. Okay, so this concludes our chapter. Hope you will read this chapter. Good luck. Thank you.